So the topic, I actually came up with the topic. I was going to talk about something different. And I had talked to Dr. Chohan about talking about pituitary macroadenomas and large macroadenomas. And then over the course of the past 4 to 5 months, I had this string of lymphoma. And it's one of those things where I remember from my training, maybe 2 or 3 cases of CNS lymphoma, it's a relatively rare thing. And then just really over the course of, like I said, 5 months, it was bam, 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 and just case after case of lymphoma, which led me to sort of go down the path of updating myself on what I should be doing as a neurosurgeon, because sort of your gut instinct of what to do with some of these cases versus what the literature tells us to do with some of these cases is counterposed to one another. So let's see here. So I don't have any disclosures. So just go through some cases. So a 30-year-old male presenting with persistent vertigo for 2 weeks. He was initially treated at an outside hospital for benign positional vertigo. They had given him meclizine. That really didn't help any of his symptoms. They persisted, and then he began to have nausea and vomiting. He went back to the outside hospital. He was awake and alert, or N times 3, and he had truncal ataxia, but otherwise he was neurologically intact. This was his original head CT. So the original head CT shows this hypodensity in both cerebellar hemispheres. The original presumption is that he had, maybe had some type of stroke, and he was transferred to our organization for further evaluation and treatment. Again, I saw him in the emergency room, truncal ataxia, and headache. His nausea had improved with some medication. And we got an MRI, and these are the MRI sequences. So the top left here is a flare signal. He had flare signal surrounding the dentate nuclei bilaterally, entering into the cerebellar peduncles. And then this is the bottom left is the T2 signal showing a similar. The top right is diffusion restriction. There was some diffusion restriction. And then this contrasted T1 on the bottom right showed this very nice enhancement of the dentate nuclei with the enhancement edema. And so, it was 30-year-old male presenting with, symptoms associated with this lesion for sure. And then the question became is what is this lesion? So we went down the path of, the initial workup. He had a CT chest, abdomen, pelvis that was negative. He had labs that were drawn. And so we diagnosed him with HIV. And technically he was diagnosed with AIDS. He had a HIV positive with 255,000 viral load. His CD4 count was 15. His CSF was positive for JC virus. His CSF was positive for Epstein-Barr virus. And then his CSF cytology was negative. I'm not sure how many people are with us now, but I would be interested at this stage, thoughts from providers as to what you would do next. So you have a person who comes in, has got a posterior fossa something, they have this imaging findings that look like something, and he has these lab values. And in a setting of, AIDS, there's any number of things that are along the potential diagnosis in the differential. So this was the differential from our radiologist. It was, infectious, inflammatory demyelination, cerebellitis, sarcoidosis, and neoplasm, such as lymphoma, also considered. we've talked about this. The lesion itself really did not look volume positive. There was, I don't know if you can see here very well, but there was this leptomeningeal enhancement. There was enhancement of the white matter and the gray matter as well. So went to the literature, and so the American Association of Neurology has a neuroinfectious disease workup recommendation. And so a person who's immune suppressed, who, give me 2 seconds to tell my kids to hush. Hey boys, be quiet. Sorry about that. So a patient who comes in with neurological symptoms and they get an MRI and they're immune suppressed, if they have, high T2 signal, high flare signal, plus or minus enhancement, plus or minus mass effect, and they have JC virus positive, then it is definitive PML. So that was the presumptive diagnosis for this individual. So he was treated for presumed PML and initiated on antiviral therapy for HIV. He was started on dexamethasone by our Neuro-Oncology service, and then the plan was for a short interval follow-up MRI in 4 weeks, because while PML was the presumed the diagnosis, there was some question and concern that maybe it was not correct. So that was the plan. But then he returned in 2 weeks with progressive headache, nausea, vomiting, and lethargy. And now he has this MRI. So significantly much more enhancement. And to complicate things now, he has reconstituted his immune system with his HIV retroviral therapy. And there's a known entity of PML that becomes, avidly enhancing after reconstitution of an immune system. So that sort of blurred the picture, but he was getting progressively worse. And so we decided to take him for a biopsy. So biopsied, and really after we did the biopsy, the biopsy was just essentially a small burr hole opening over this area, and we grabbed a piece of tissue, but getting that biopsy seemed to anger the tumor. He had hydrocephalus. We were treating that with an EVD. And then the pathology came back as diffuse large B-cell lymphoma. The patient was on high-dose steroids. EVD was used to treat the hydrocephalus. The pressure of the hydrocephalus was a low-pressure hydrocephalus. And the patient just continued to really decline. And so we initiated him on high-dose methotrexate with our oncology team. In spite of him having an open posterior fossa, it wasn't open, but a fresh posterior fossa wound, we thought that without treatment that he was not going to survive. And so we initiated that very early, about two days after surgery. And he remained hospitalized with an EVD, waxing and waning neurological exam. And this thing just continued to progress and continued to grow. Ultimately, the family elected to withdraw care, and the patient succumbed to his disease. So non-Hodgkin lymphoma is relatively rare. Secondary CNS lymphoma is seen in 2 to 10% of patients with systemic non-Hodgkin's lymphoma. And most of these patients are recurrences of the original lymphoma when they develop CNS lymphoma. And then primary CNS lymphoma represents 4 to 6% of all extranodal lymphomas and 4% of all CNS tumors. And there's some evidence that the incidence is increasing in the population. And treatment strategy is based actually on not a lot of, for primary CNS lymphoma, not a lot of data. I was a bit surprised when I went to review the literature. There are only 3 randomized clinical trials evaluating therapy, and those therapies are, driven by historical presumptions. And so there's not really any new therapies that have been tried in quite some time. And the sort of the hallmark of therapy is high dose methotrexate and whole brain radiation therapy. So imaging for primary CNS lymphoma typically follows this course. These are the hallmarks of lymphoma. So there's enhancement on T1 with contrast, flare signal surrounding the enhanced region, and then the enhanced region has diffusion restriction because lymphoma is a very dense tumor, highly cellular, very tightly packed cells, and so the water content within that cell mass is not able to diffuse in the normal patterns. Treatment and prognosis. So this is the largest randomized controlled trial. It's actually the only phase 3 trial that has been completed in primary CNS lymphoma. It was 551 patients who were randomized to methotrexate with whole brain radiation, which was 45 gray and 30 fractions, or methotrexate without whole brain radiation. And looking at all patients, the overall survival was 32 months in the chemotherapy with whole brain radiation, and then 37 months in the chemotherapy without brain radiation. So it was a non-inferiority trial. It was trying to determine whether chemotherapy alone had the same benefit as chemotherapy with radiation. And it didn't meet the threshold to say that chemotherapy alone was non-inferior, but there's a signal there. And the ultimate recommendation from the trial was that the standard care of methotrexate plus whole brain radiation is the best, but you have to measure that against the neurotoxicity of whole brain radiation. But overall survival in patients with primary CNS lymphoma ranges from 32 to 37 months as a median time to survival. So then the question, you ask yourself as a neurosurgeon when you have somebody who has an adverse event, is should I have resected this lesion? So again, going back to the literature and evaluating, the initial presumptive answer is no, based on clinical guidelines. So, from the Journal of Clinical Oncology, who has the most updated clinical guidelines for primary CNS lymphoma, is the role of surgery is generally restricted to stereotactic biopsy due to widespread and diffusely infiltrative tumor. And I didn't show you on that other that the patient 1, but he had multiple smaller areas of enhancement scattered throughout the white matter in his supratentorial region. There's no, quote, survival benefit from subtotal or gross total resection. And that really comes from the neurosurgery literature. So the primary intracerebral malignant lymphoma report of 248 cases in 2000 showed that, and I don't fully understand their statistics. My interpretation of this is that a complete resection resulted in a survival benefit. But stereotactic biopsy resulted in a risk of death, and a partial resection resulted in an increased risk of death. I think that their rationale here is that because this crosses over the risk ratio of 1, that stereotactic biopsy and complete resection were equivalent. So, and then in another study, there was a review of over 1,100 patients of immunocompetent patients. They looked at the impact of surgery on survival and looked at radical resection versus subtotal resection versus biopsy alone. And the median survivals of that group were 17, 15, 16, and 22 months. And that there was no survival benefit in surgery. And so if you look at the survival chart over here to the right, this line here, this 39, that is in line with the untreated patients. And looking at the results from this group, essentially what surgery at this time did is that if you had a surgery, then that your chemotherapy regimen and radiation were significantly delayed. And so I don't know that it was necessarily the role of surgery was, resulting in the adverse event. It was that surgery prevented you from getting the therapy that was going to improve your outcome. So from primary CNS, is there a role of surgery? Well, maybe. So they went back and they looked at that phase 3 trial, which is the German primary CNS lymphoma study, and did a subgroup analysis post hoc of patients who underwent surgery. So there were 67 patients who underwent gross total resection, 70 patients who underwent subtotal resection, and 379 who underwent biopsy. And when you look at the factors in terms of age, risk groups, these groups were fairly well balanced. And what they found in the subgroup analysis is that there appeared to be a significant improvement in outcome following a gross total or subtotal resection compared to biopsy alone. And the results and the conclusions from this study were that the idea that surgery was not, and when I say surgery, I mean surgery in the sense of surgery to do a cytoreductive type of surgery, that idea of cytoreduction not being beneficial may not hold true for all patients, and that there may be some group who does benefit from resection of primary CNS lymphoma. So looking at their progression-free survival by extended resection, the bottom line is biopsy alone. The top line is complete resection. And again, over here to the right, extent of resection, overall survival by extent of resection. The bottom line being biopsy, the top line being complete resection. So the subgroup analysis from a relatively large trial did suggest the possibility of improvement in outcome. But again, back to that aspect that I was talking about earlier, when you delve into these patients, there was really a push to not limit the initiation of chemotherapy and radiation in this group after the surgery was completed. So there may be a timing component to this, that if you're going to do surgery, then you have to accept the risk of initiating these therapies sooner rather than later. So in my 6-month saga of lymphoma, I had another patient come in. So 62-year-old female with diabetes and hypertension who presented with a growing scalp mass over the past several weeks. She came in, she was awake and alert, neurologically intact. She had a very prominent right parietal scalp lesion that was non-tender and non-mobile. It wasn't painful. So this was her original CAT scan that shows this, what appears to be an extraaxial lesion eroding the bone underneath the skin and the subcutaneous tissue in the temporalis muscle in the right frontal parietal region with some mass effects. You see some cerebral edema here on the brain parenchyma. This was the MRI. So the top left is the DWI, the diffusion. So diffusion restrictive. This is a coronal contrast T1 showing this extraaxial mass, eroding through the skull into the soft tissues of the scalp. Again, axial T1 with contrast, and the T2 again shows that what appears to be a very clear delineation between the brain parenchyma and this lesion, and it did appear to be extraaxial. So the MRI report from this was primary neoplasms, atypical meningioma, hemangioparasitoma, primary osseous tumor, lymphoma, and metastatic lesions are possible, but less likely. So she was planned for surgery. So hers was a combination of, mass effect and this eroding through the bone. And so the plan was for resection and a cranial vault reconstruction. The primary consideration at the time was thought to be an atypical meningioma. And then she returned to the emergency room with altered mental status and a left hemiparesis. And now when you look underneath her hair, the lesion is eroding through the scalp. The top is her initial CT scan, and then a very short interval 2-week CT scan down below showed, a significant increase in the size. And then if you see here that she had significant more edema, she was beginning to trap this ventricle. She was declining rapidly, and so she was taken urgently to surgery for a resection. Opening up, the tumor was very soft, friable. It came out relatively, essentially, came out with the sucker. The bone, we didn't really do a craniectomy. It was just that when we opened up, that all of this bone was gone. And so we replaced it with a titanium mesh. And this is her post-op CT scan on the bottom. And immediately after post-op, she was opening her eyes to voice. She was regarding, following commands. She was not, wide awake. She was localizing bilateral upper extremities, but she was pretty close to what she was pre-op in terms of mental status, and her hemiparesis appeared to be improved. And then on post-op day number 2, she would open her eyes to voice, regard. She would follow commands on the right, but she had developed a relatively sudden left hemiplegia. And we got a follow-up CT scan that shows this intraparenchymal hemorrhage. And the ultimate diagnosis was a large B-cell lymphoma, not otherwise specified. And the etiology of the hemorrhage was felt to be likely a venous infarct, given the timing and just the clinical picture of doing well, and then sort of this progressive decline to, have this hemorrhage. So, venous infarct with resultant intracranial hemorrhage, we manage that conservatively. My experience with venous infarcts is that if you can get them over the acute phase, is that they tend to make a pretty good neurological recovery. And so we talked to the family about that. Her problem now is that she has a hemiplegia, a venous infarct, and primary CNS lymphoma. She was begun on high-dose dexamethasone. We discussed her with oncology, and given her rapid, so after we did the surgery, she stabilized, and we waited for about 4 weeks and told oncology that they could initiate chemotherapy at that time. They discussed with the family, and because of her current comorbid condition, they elected to not initiate therapy and transitioned her to hospice approximately 8 weeks from her diagnosis. Then, so patient 3 was a 21-year-old who hit his head while he was working underneath a truck. He's a diesel mechanic, and he noted that he had a knot develop on his scalp, and was evaluated by an outside plastic surgeon. And they thought that the knot was a hematoma, and so they took him and they washed it out, and then it came back, and then they thought it was an infection, and so he underwent 4 versions of some type of washout out at this outside facility, and without any biopsies being sent. And then he presented to us because of just progression of this, wake and alert oriented ×3. Everyone, when we were consulted for what people thought was going to be a presumed sort of some type of fungal infection. And so this is his picture of him. So this very large, so this whole area here was this very firm, tense lesion. This was this necrotic tissue. Again, necrotic tissue here sort of weeping and oozing. If you palpated his neck was not supple like you would expect someone's neck to be, very hard and firm. So this is the original CAT scan at the top. So this extracranial lesion underneath the scalp, actually eroding through the scalp, this extraaxial lesion, this moth-eaten frontal bone here. And then the MRI shows this again, this diffusion restriction, and with contrast, this enhancement. But the enhancement you can see on the dura is not just, this singular lenticular shape area here. The enhancement extends all the way back. This is a coronal. What I want you to see here, so this is that original scalp lesion that's necrotic on the picture, but all of this down past his parotid, following this, what we, the lymph nodes down through his neck. And so he was taken for a biopsy and got a piece of tissue. So he had a punch biopsy done by, I think, dermatology or some service, and that came back negative. So we just took him to surgery to get some definitive tissue. He had anaplastic large cell lymphoma, ALK1 positive, and he was initiated on high-dose methotrexate. And then this is his 1-month follow-up. So This scalp lesion is almost completely resolved. He still has a little bit down here around his parotid, but just from this, all of this here to this here in a very short interval. Very responsive to chemotherapy. And then patient 4. So this is a 68-year-old female. She had a history of sarcoidosis, who presented to a primary care physician with an enlarging lump on the left side of her head since December. The patient and the family noted the size of the lump had increased very rapidly, and she was evaluated by a plastic surgeon who was going to remove it, but thought better and decided to get a CT scan. She came in, she was neurologically intact. She had a tense compressible mass over the left scalp, temporal scalp region. So this was her original CAT scan. So this extracranial, intracranial lesion, but the bone itself looked uninvolved. So the diffusion restriction, so again, restricts diffusion. The T1 shows this extraaxial mass underneath the scalp, extra skull, and then the enhancement. Again, this dural enhances beyond the mass itself, enhancement underneath the scalp, and again, the bone did not appear to be involved. So she was taken for just a biopsy, and then path came back as a low-grade B-cell lymphoma, most consistent with follicular lymphoma. She's had recent PET scans, and her PET scans are negative after initiating of chemotherapy. So conclusions. So primary CNS lymphoma continues to be a relatively rare CNS oncologic diagnosis, but its incidence appears to be rising. That's based on personal experience, and that I think I've seen more in the past 6 months than I've seen in most of my career. The mainstay of treatment has and continues to be high-dose methotrexate. That's because methotrexate penetrates the CNS blood-brain barrier and whole brain radiation. The whole brain radiation, the data on that is that the tumors themselves are exquisitely radiosensitive, but the neurotoxicity related to whole brain radiation may not be worth the survival benefit in some patients. And so that came from that German study. And then neurosurgery plays a critical role in diagnosing these tumors when CSF studies are unrevealing. However, the role of cytoreductive surgery remains unclear. So, in terms of what I've shown you today, I've shown you one patient that maybe I should have taken to surgery. I show you another patient that maybe I should not have taken to surgery. And then I've shown you 2 patients that I did a minimal sort of biopsy type approach, even though they had, substantial tumor, and they did better. So, the problem with neurosurgeons is that we very often treat our next patient like the result of our last patient. So if something went well, we'll do it over and over again. But I really want to try to be sort of data driven in how I approach these things. And I'm not perfectly clear on what the right answer is. I think more needs to be done to answer these questions. The problem is again, because of the rarity of the disease, it's difficult to consolidate that information in a meaningful way.